Welcome to This Week in Endocrinology. This week, we're covering 10 notable papers spanning new frontiers in type 2 diabetes, pharmacotherapy, precision genetics and personalized care across the diabetes spectrum, and long-term risk in survivors, from childhood-onset type 1 diabetes to young people treated for thyroid cancer. Let's dive in. We start with incretin-based therapy, where two phase 3 trials in the Lancet Diabetes and Endocrinology push in different directions, one toward simplifying injectable therapy, the other toward avoiding injections altogether. In combined 4, reported by G and colleagues, 485 insulin-naive adults with type 2 diabetes and a baseline hemoglobin A1C of around 9.5% were randomized, open-label, to once-weekly IcoSema, the fixed combination of insulin icodec and semaglutide, or to once-daily glargine U100, both titrated to target over 40 weeks. IcoSema lowered hemoglobin A1C by about 3.33 percentage points versus just under 2.5, with glargine, a treatment difference of roughly 0.9 of a percentage point in favor of the combination. The weight story was arguably more striking. Body weight fell slightly on IcoSema, while it rose by nearly 4 kilograms on glargine, a between-group difference of about 4.5 kilograms. Clinically significant or severe hypoglycemia was also roughly halved, at about 0.3 versus 0.6 episodes per person year. Gastrointestinal side effects were the main tolerability issue, as you would expect from the semaglutide component. For a patient failing oral agents who needs insulin, this is a once-weekly injection that outperforms daily basal insulin on glucose, weight, and hypoglycemia simultaneously. Though remember, this was open-label, and the titration target was tight. Alongside that, Yabe and colleagues report Achieve-J, a 52-week open-label safety study of the oral GLP-1 receptor agonist orforglipron in just over 400 Japanese adults with type 2 diabetes, randomized to 3, 12, or 36 milligrams daily on top of diet and exercise or 1 or 2 oral agents. The primary endpoint here was safety, not efficacy, and the signal is dose-dependent tolerability rather than any new hazard. Around 85% of participants had at least one treatment-emergent adverse event, most mild or moderate, but discontinuation for adverse events climbed from about 1 in 20 at the lowest dose to about 1 in 7 at 36 milligrams, driven by gastrointestinal symptoms. Level 2 hypoglycemia was rare, around 2% in the higher dose groups, and there was no severe hypoglycemia. The practical message is that an oral GLP-1 receptor agonist appears acceptably safe over a year in an East Asian population, but that the top dose carries a meaningful attrition cost, which argues for slow titration and honest counseling about nausea. Staying with drug classes, the European Journal of Endocrinology published a large target trial emulation from Wang and colleagues that widens the lens on SGLT2 inhibitors well beyond glucose. Using linked English primary care, hospital, and mortality data from 2012 to 2023, they compared more than 364,000 adults over 40 with type 2 diabetes, starting either an SGLT2 inhibitor or a DPP4 inhibitor, and tracked 59 pre-specified long-term conditions across 17 organ systems. SGLT2 inhibitor initiation was associated with roughly a quarter lower all-cause mortality, about a 14% lower risk of a first hospitalization, and fewer hospitalizations overall. Risk was lower for 28 of the 59 conditions, including dementia, cancer, steatotic liver disease, diabetic foot ulcer, epilepsy and rheumatoid arthritis, and higher for 4, notably candidiasis and diabetic ketoacidosis. This is observational, and a benefit spanning epilepsy and rheumatoid arthritis should make any of us think about residual confounding and healthier user effects. But the direction of travel is consistent with the trial evidence, and the ketoacidosis and genital mycotic infection signals are real and actionable at the point of prescribing. That liver finding connects neatly to a review in Diabetologia from Yuki Jarvinen and Roden, who argue that metabolic dysfunction-associated steatotic liver disease should be treated as a core feature of type 2 diabetes rather than an incidental comorbidity. Their central number is uncomfortable. Up to 95% of MASLD cases remain undiagnosed, partly because there is no accepted standard for assessing steatosis. while non-invasive tests tend to overestimate progression in type 2 diabetes. They emphasize that the combination of type 2 diabetes and metabolic syndrome features strongly predicts liver outcomes, yet cardiovascular disease remains the leading cause of death in non-cirrhotic MASLD, so finding fibrosis does not displace cardiometabolic risk management. They also flag genetic heterogeneity, with the PNPLA3I148M variant raising liver risk while possibly protecting against cardiovascular disease. With drugs now approved for steatohepatitis, the bottleneck has shifted from treatment to case finding, and that responsibility sits substantially with endocrinologists. Precision approaches ran through several papers this week. In the Journal of Clinical Endocrinology and Metabolism, Clément and colleagues present a European expert consensus on rare monogenic obesity, POMC, PCSK1, and LEPR deficiencies, and Bardet-Biedl syndrome, arguing that with MELANOCORTIN, 4 receptor agonists now approved for conditions affecting as few as 1 in a million people, care should be concentrated in designated centers of expertise. Their framework is worth internalizing: early and precise genetic diagnoses, equitable access for eligible patients, structured monitoring with a willingness to stop therapy when there is no measurable benefit, and real-world data collection to fill the long-term evidence gap. In diabetes care, Murray Leach and colleagues take a complementary genomic approach in over 1,100 insulin-treated people referred for MADI testing, adding a type 1 diabetes genetic risk score to the gene panel. Roughly 1 in 5 of those referred actually had genetic signatures consistent with type 1 diabetes, and among those whose MADI testing came back unsolved, the score reclassified about 16% as probable type 1 diabetes. As a pre-testing triage tool, it discriminated poorly overall, but performed well in children under 10, where more than half of tests could have been avoided without missing MODI. So in young children, the score can spare unnecessary panel testing. In adults, it is better used to interpret a negative panel than to decide whether to order one. 2 further papers in diabetes care address type 1 diabetes management and outcomes. Nielsen and colleagues linked a New South Wales registry of over 5,200 children diagnosed with type 1 diabetes before age 16 to hospital, emergency, insurance, and death records. Within 20 years of onset, incidence ranged from about 9 per 10,000 person years for cardiac complications to about 53 per 10,000 for kidney complications. Diagnosis before age 7 compared with diagnosis at 13 to 16 was associated with substantially lower 20-year risk across almost every outcome. Peripheral neuropathy risk was around a sixth, severe retinopathy a quarter, cardiac complications about a third, and kidney complications roughly 60% lower, with lower limb infections the exception. Importantly, risk did not differ by attained age, supporting the idea that prepubertal onset disease progresses to complications more slowly. That is reassuring for families of very young children, but the corollary is that adolescent onset diabetes deserves earlier and more intensive complication surveillance. Then Runchi and colleagues report a randomized trial of time-restricted eating in adults with type 1 diabetes and overweight or obesity. 32 participants assigned for 6 months to an 8-hour eating window without calorie counting, to 25% daily calorie restriction, or to no intervention. The primary outcome was negative. Body weight did not change significantly with either strategy relative to control or between the 2 diets. Hemoglobin A1C did fall modestly more with time-restricted eating than with calorie restriction, by about half a percentage point. And reassuringly, there was no excess of ketoacidosis, severe hypoglycemia, or severe hyperglycemia. With only 32 participants, this is a safety and feasibility signal, not a weight loss endorsement. Rounding out the week, 2 papers address longer-term risk after intervention. In Diabetologia, Rogers and colleagues report a non-randomized phase 2 multicentre study of belatacept plus sirolimus as maintenance immunosuppression and islet transplantation for type 1 diabetes with hypoglycemia unawareness, comparing 9 recipients with a contemporaneous cohort of 24 on tacrolimus and mycophenolate. 8 of the 9 on belatacept and sirolimus met the composite primary outcome of freedom from hypoglycemia, with detectable C-peptide and hemoglobin A1C under 7% at 12 months, compared with about half of the tacrolimus group, and renal function remained unchanged only in the belatacept arm, with higher regulatory T-cell proportions. 9 patients is a very small, non-randomized comparison, so treat this as a rationale for a proper trial rather than a change of standard. And in thyroid, Bello and colleagues followed more than 5,200 survivors of differentiated thyroid cancer diagnosed before age 40, matched 4-to-1 to cancer-free controls over 4 decades. Second primary malignancies were about 50% more common in survivors and appeared after a shorter latency. The radioactive iodine gradient is the clinically important part. Compared with untreated survivors, 1 course of radioactive iodine was associated with roughly double the risk of a second cancer, and 2 or more courses with nearly a tripling. Overall mortality was low and similar to controls, but was higher among those who developed second cancers or received radioactive iodine. That is a strong argument for risk-adapted, parsimonious radioactive iodine use in young patients, and for surveillance that extends well beyond a decade. If you only have time for 1 paper this week, make it combine 4 in the Lancet Diabetes and Endocrinology. A once-weekly injection that beats daily basal insulin on hemoglobin A1C weight and hypoglycemia at the same time changes how you frame the conversation about starting insulin. Here are the key takeaways from this week in endocrinology. First, once-weekly insulin icodec combined with semaglutide outperformed daily glargine across glucose, weight, and hypoglycemia in insulin-naive type 2 diabetes, with gastrointestinal effects the main trade-off. Second, oral orforglipron looks acceptably safe over a year in Japanese adults, but discontinuation rises steeply at the 36 mg dose, so titrate slowly. Third, large-scale English data associate SGLT2 inhibitors with lower mortality and hospitalization and reduced risk across 28 long-term conditions, alongside genuine signals for candidiasis and ketoacidosis. Fourth, steatotic liver disease is massively underdiagnosed in type 2 diabetes, and case finding now sits with us, since effective drugs exist. Fifth, adolescent-onset type 1 diabetes carries substantially higher 20-year complication risk than prepubertal onset, and time-restricted eating did not produce significant weight loss in type 1 diabetes, though it appeared safe. And finally, cumulative radioactive iodine dose tracks with second primary malignancy risk in young thyroid cancer survivors, reinforcing risk-adapted use and long surveillance. That's your roundup for this week in endocrinology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And a quick rating on Apple Podcasts or Spotify helps other physicians discover the show. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.